Hello, everyone, and welcome to our ENDO 2023 Obesity News Conference. We're happy you all could make it today. My name is Colleen Williams, and I'm the Senior Manager of Communications at the Endocrine Society. Today's news conference will focus on the latest research in obesity, and we are pleased to have with us today Dr. Emily Farrell of the University of Michigan in Ann Arbor, Ayush Visaria of Rutgers Robert Wood Johnson Medical School in New Jersey, and Seema Fonsa of the Mayo Clinic in Rochester, Minnesota. Over the next 30 minutes, each speaker will present their findings, and then we will end with a Q&A. Please note that this news conference is being broadcast live via webcast, and that there are many journalists online with us right now. Because we are broadcasting live via the web, it's important for all remarks to be made into a microphone to enable those who are joining us virtually to be able to hear what's being said in the room. Journalists who are attending online will be able to type their questions into the chat at any point during the news conference, and they'll be addressed during the Q&A. I would now like to invite our first presenter, Dr. Farrell, to speak.
Thank you, Colleen, and thank you everyone for having me here today. As she said, I'm Emily Farrell from the University of Michigan, and today I will be talking to you about my study, the association between metabolic syndrome and food security in a reproductive age Latina population. I'll start with my author disclosures and some background. So, metabolic syndrome. This is a medical condition that is based on 5 diagnostic criteria, which puts patients at increased risk for adverse health outcomes, often related to diabetes, heart conditions, and stroke, all of which have been found to also have negative outcomes in pregnancies, peripartum, and the postpartum. Metabolic syndrome is at a prevalence of about 33% in the US population. This is slightly higher, actually, in our Hispanic community at closer to 35%. Data further indicates that studies over time have shown certain areas where this prevalence is increasing, and that is specifically in the Hispanic population, younger populations aged 20 to 39, and women. Food security is a social determinant of health that has been found to influence health outcomes as well. According to the American Institute of Nutrition, food insecurity is defined as limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in a socially acceptable way. Food insecurity in the US is a major health concern, at about 11% of households having limited access at all times to enough food for activity and healthy living. This was based on a 2019 study, and due to the pandemic of COVID-19, this food insecurity is actually estimated to be higher at about 38% today. The objective of my study was to compare these two variables. So I aim to assess the relationship between metabolic syndrome and food security in this large cohort of reproductive age Latina females. So let me tell you a little bit about this cohort. This study was based off of a much larger study, the Environment, Leiomyoma, Latinas, and Adiposity Study, or AYAS. This is an NIH-funded longitudinal study that enrolled patients from 2018 till 2021. All participants were aged 21 to 50 at the time of enrollment from Southeast Michigan. We had 706 participants enrolled, 621 completed the first study visit, and these patients received extensive questionnaires that they filled out, including questions of food security. They also had blood samples taken and baseline measurements performed. So we defined metabolic syndrome based on the American Heart Association diagnosis. The measurable parts of that diagnosis include these 5 variables: waist circumference greater than or equal to 88 centimeters, which is specific to women, serum triglycerides greater than 150, HDL cholesterol less than 50, a systolic blood pressure greater than 130, or a diastolic greater than or equal to 85, and then fasting glucose levels of greater than 100. The food security scores that we obtained were based on the U.S. Household Food Security Survey model, which is a validated study that includes questions answered with scores ranging from 0 to 6. Higher scores indicate a lower food security status. These questions include ones such as, I couldn't afford to eat a balanced meal, the food that I bought just didn't last and didn't have money to get more. In the past 12 months, have you ever cut the size of your meals or skipped meals because you could not afford food? So all very tailored, obviously, to identifying those who were struggling with their excess. The findings that we had from this study included 584 participants with enough diagnostic criteria to be counted towards potential metabolic syndrome. The average age was 37.6, mean BMI of 30, and of the participants noted to have metabolic syndrome was 203, and that was 34.4%. The average food security score was 0.83. The prevalence of metabolic syndrome we found was positively correlated with age. As you can see, as age increases, so does the metabolic syndrome. And then when comparing to food security and looking at those with high food security, we identified that 33% of our cohort had metabolic syndrome. And then for low security, nearly half had metabolic syndrome. And for the very low food security, we were at 44.4%. So the large finding here is that among the cohort of reproductive age females, food security status is in fact significantly associated with metabolic syndrome, with a p-value of less than 0.01. Conclusions that we can draw from this are that we need to focus our efforts to improve food security among this cohort. This will have the potential to reduce the metabolic syndrome as well as those adverse health outcomes of cardiovascular disease, metabolic, and ultimately reproductive adverse health outcomes. The clinical implications that I am taking away from this is that obviously our cohort is reproductive age females, focusing on the providers who will be interacting with them. With an average parity of 3 pregnancies in this cohort, they would most likely have interacted with a reproductive provider at some point, and educating those providers to be aware of food security and its links to metabolic syndrome could potentially help improve the care of those patients. We need ongoing screening, whether in those reproductive clinics or other clinics, to ensure that patients have access to food. And with that, if they don't, they need to be provided with information and access to resources to improve their access to food and reduction in poor health outcomes. Another notable aspect of the AS study is that word of mouth is very powerful in this group. Many of the participants noted that their knowledge of health and well-being comes from those around them and not necessarily from some of the resources that other populations may have. So being able to get the information out there so that they can disperse it among themselves also is something that I think we can focus and do a better job at. I would like to thank Dr. Marsh and the AS team for allowing me to take on this study and use their data. And these are some of the references for the background information that I provided earlier. Thank you.
right. Thank you very much, Dr. Farrell. I'd like to now invite Dr. Rosaria to present his research.
Good afternoon, everyone. My name is Ayush. I'm an internal medicine resident at Rutgers Robert Wood Johnson Medical School in New Jersey. And today I'll be presenting on discordance between BMI and DEXA-based adiposity measures among US adults. So to start, I want to give a little bit of history into BMI. So it was actually developed in the 1800s by a Belgian mathematician, Adolphe Quetelet, as weight over height squared. And it was actually his goal in life to describe adiposity in the average man. And at that time, it wasn't really used for clinical care. It was more used by insurance companies. But then over the next 100 years, more research was done. And then it was formally coined as BMI by Dr. Ansel Keys, who extensively tried validating the coefficient. It's since become a ubiquitous marker of population health and clinical decision making. However, there are many limitations. BMI does not differentiate fat from muscle, from bone, from water weight, does not account for body fat distribution. So if we see this figure on the right, two people could have the same BMI, but their fat is distributed differently. And we now know that risk differs based on where the fat is. It's also not well validated in diverse populations. Most of the studies that were done in the 1800s and 1900s were done in middle-aged white European men. So it's still not 100% known. It's not well validated in other populations. So with that in mind, our research question was, among a contemporary nationally representative sample of US adults aged 20 to 59, how well do the BMI cutoffs that we currently use correlate with DEXA-based obesity? How well do these correlations differ by race ethnicity? And how does body composition and body fat distribution differ by race ethnicity? So to answer this question, we used the National Health and Nutrition Examination Survey from 2011 to 2018. So the NHANES is it's a survey that's done every 2 years by the CDC, and they basically measure a whole bunch of different parameters, one of them being whole body DEXA scans, and the other is various questionnaires, BMI, waist circumference, etc. Our population was 9,784 US adults aged 20 to 59. BMI was classified into the WHO ethnicity-specific cutoffs for obesity, which, if we look at this third line here, greater than or equal to 30 for everyone, and then greater than or equal to 27.5 for Asians. And DEXA measurements included total body fat percentage, which is basically what percent of your body mass is fat, android to gynoid fat ratio, which is the amount of fat in your android or abdominal region compared to the gynoid or hip and thigh region. We looked at the ratio of fat from android to gynoid. We also looked at leg fat percentage, so what percent of your total body fat is in your legs. Both the android to gynoid fat ratio and leg fat percentage are measures of body fat distribution. And the cutoffs we used for total body fat to determine obesity using the DEXA scans was greater than or equal to 25% for males, greater than or equal to 32% for women or females. And that's based on the American Council of Exercise and the American College of Sports Medicine. So we now looked at a 2x2 table. The left-hand side shows obesity based on BMI, and the top two columns are DEXA-based obesity. And what we see in red are the ones that are discordant. So this 3,716 is people who have obesity per the DEXA scan, but no obesity per the BMI greater than or equal to 30 and greater than or equal to 27.5 cutoff. In total, about 3,835 individuals, representing around 47 million nationally, have BMI classifications that differ from DEXA-based obesity measurements. And about 51 to 55% of young to middle-aged adults have obesity but are incorrectly classified as not having obesity using the BMI cutoffs. We now added waist circumference to this using the same cutoffs that she had talked about earlier, greater than or equal to 88 centimeters for women and greater than or equal to 102 centimeters for men. And actually, it improved obesity detection quite a bit. Adding waist circumference reduced the number of people mistakenly classified as not having obesity by 23%, which, if we were to represent the entire United States, about 19 million US adults. Next, we looked at what percent of the population by race and by BMI group actually have obesity per the DEXA scan. And there's a lot of numbers here, but basically we see that even among people with normal BMI, 27 to 49% have obesity per the DEXA scan. Overall, the number was around 43%. And there is also various variable distribution by race ethnicity. And then we also looked at gender differences. Again, we see differences there as well, where females tend to have higher rates of obesity compared to men using the DEXA scans. Next, we want to look at the racial ethnic differences in odds of obesity. And again, there's a lot of numbers here, but basically, we show here that Hispanic and Asian adults tend to have higher odds of obesity despite having normal BMI. If we look on the figure on the left, both of those top two lines are above 1. When we look at the overweight BMI group, there's no clear difference, although non-Hispanic Black individuals in both normal BMI and overweight BMI tend to have lower odds of obesity compared to non-Hispanic white groups. Next, we looked at body fat distribution, so leg fat percentage. We see, again, a wide distribution of leg fat percentage across the different BMI groups, and also racial ethnic differences. Non-Hispanic Black adults tend to have higher leg fat percentage compared to the other racial ethnic groups. And Hispanic and non-Asian, Hispanic and non-Hispanic Asian groups tend to have lower leg fat percentage. And then if we look at android to gynoid ratio, again, there's a lot of numbers, but just try to look at the colors and variability in all the numbers. We see that there are clear differences between males and females. The figure on the right is males, the figure on the left is females. And then there's also variability across racial ethnic groups. Non-Hispanic Black adults tend to have lower android to gynoid ratio, meaning they have less abdominal obesity compared to their hip and thigh obesity or adiposity. So in summary, nearly 3 in 4 young to middle-aged US adults have obesity via the total body fat percentage estimated from the DEXA scans, more than half of whom are incorrectly classified as not having obesity per the BMI. Adding waist circumference reduced the number of people mistakenly classified as not having obesity by 23%. Normal BMI Asians and Hispanic adults were more likely to have obesity and more likely to have a greater proportion of abdominal fat compared to non-Hispanic white adults. And non-Hispanic Black adults had significantly lower likelihood of having obesity at normal or overweight BMI ranges, and also had a lower proportion of abdominal fat. So what are the clinical implications? I think the biggest thing here is BMI is used throughout population health, throughout clinical care, but what we realize here is that BMI vastly underestimates true obesity, suggesting its use alone without an additional measure like waist circumference may not be sufficient. And there also exists racial ethnic differences in both body composition and body fat distribution. Future studies need to really characterize these differences and then also look at the downstream outcomes. Do these discordant individuals who may have obesity per the DEXA scan but not per the BMI cutoffs actually have long-term cardiometabolic health outcomes? That's the next step. Yep. Thank you.
Thank you so much, Dr. Vazaria. We'd now like to introduce Dr. Fonsa.
Good afternoon. My name is Sima Fansa. And first, I would like to thank ENDO Society for the invitation today. And on behalf of my co-authors, I would like to present our project about the efficacy of anti-obesity medications among breast cancer survivors who are taking aromatase inhibitors. So I have no financial disclosure or conflicts of interest in this presentation. Starting with our central finding, in our retrospective study, we showed that breast cancer survivors who are taking aromatase inhibitors have a suboptimal weight loss response to anti-obesity medications. As a little background to our study, what is the role of aromatase inhibitors in breast cancer? So, aromatase inhibitor prevents estrogen production by blocking the action of the aromatase enzyme, mostly in the adipose tissue, which is also known as body fat. On the image on the right, we can see that aromatase inhibitors prevent the conversion of androgen to estrogen, so that estrogen cannot stimulate the growth of breast cancer cells. And in postmenopausal women with hormone receptor positive breast cancer, aromatase inhibitors are used as adjuvant endocrine therapy to improve overall breast cancer outcomes. How do aromatase inhibitors affect weight? So aromatase inhibitors tend to increase abdominal adiposity, so increase the fat percentage around the abdomen region. They also decrease muscle mass, and patients who are taking aromatase inhibitors frequently report joint and muscle pain as adverse effects. The last 2 points lead to decreased energy expenditure, and overall, aromatase inhibitor may be associated with weight gain. In fact, up to 27% of women taking aromatase inhibitors for breast cancer treatment gain weight. And what is the effect of obesity in breast cancer? So the excess adiposity that is seen from aromatase inhibitor can, on one hand, lead to an increased risk of breast cancer recurrence, which will lead to an increased breast cancer-related mortality. And on the other hand, the excess adiposity can lead to increased cardiometabolic risk, which causes an increased cardiovascular mortality. And now you may be asking yourself, why is this relevant? Actually, in breast cancer survivors, cardiovascular disease is the most common cause of non-cancer related death. Do breast cancer patients receive adequate weight management? Unfortunately, even though breast cancer survivors report high levels of concern about weight after their breast cancer diagnosis, there are significant gaps in the provision of advice or even guidelines on weight gain prevention and weight management. That being said, most patients do not receive advice on this topic at the time of breast cancer diagnosis or during their survivorship. As you may know, weight loss has a variety of health benefits, and weight loss can improve cardiovascular mortality and also improve breast cancer outcomes. And in breast cancer survivors, lifestyle intervention, including healthy diet and rigorous and consistent physical activity that result in weight loss, can decrease the risk of breast cancer recurrence and increase the recurrence-free survival in the long term. As well, bariatric surgery has been associated with a decreased risk of breast cancer recurrence. To date, there are no studies that have addressed the effect of anti-obesity medications in breast cancer survivors on aromatase inhibitors. This is why the aim of our study is to study the efficacy of anti-obesity medications in breast cancer survivors using aromatase inhibitors. And our hypothesis is the following. Aromatase inhibitor will lead to, 1, a change in body composition so that there will be an increase in fat percentage and a decrease in muscle mass, 2, a decrease in energy expenditure, and 3, muscle and joint pain. And for these reasons, we hypothesize that aromatase inhibitors will lead to a decreased weight loss response to anti-obesity medications in patients who are using them. Concerning the study methods, so our study is a multi-center retrospective study, and we compared outcomes in response to anti-obesity medications among 2 groups. The first group is the AOM-AI group, who included breast cancer survivors on aromatase inhibitors. And the second group is the AOM group, which included patients without a history of breast cancer or aromatase inhibitor use. And importantly, our groups were matched by age and body mass index. What outcomes did we assess in our study? Actually, we compared among the two groups, first, the weight loss outcomes. So we studied total body weight loss percentage at 3, 6, 9, and 12 months after the anti-obesity medication start date. And we also studied the percentage of patients achieving more than 10% of total body weight loss at 12 months. We also analyzed the changes in metabolic parameters from baseline to end of study. And these parameters included blood pressure, fasting glucose, hemoglobin A1C, which is a marker of glucose metabolism, and lipids. Concerning the results, so our cohort was mostly comprised of white women with obesity in their early 60s. And most patients had class 1 obesity. The only difference seen between the two groups was the race distribution, where the group of AUM-AI had a higher proportion of white participants when compared to the AUM group. For the anti-obesity medication usage, our study included 3 FDA-approved anti-obesity medications, which are semaglutide, liraglutide, and phentermine. And the proportion of use of these anti-obesity medications was similar in both groups. Now, what about the weight loss outcomes? So this is the most important slide of our presentation. And we showed that breast cancer survivors on aromatase inhibitors, which are represented on the red line in the graph, lost less weight at 3, 6, 9, and 12 months compared to controls, which are presented in blue on the graph. And the difference observed was only significant at 6, 9, and 12 months. And at 12 months, breast cancer survivors on aromatase inhibitors lost 42% less weight compared to controls, 5.3% for the AUM-AI group versus 9.1% for the AUM group. What about the categorical weight loss at 12 months? So breast cancer survivors on aromatase inhibitors, which are also represented here in red, were less likely to lose more than 10% of their weight at 12 months compared to controls in blue, 22% in the AUM-AI group and 48% in the AUM group. What about the changes in metabolic parameters? Interestingly enough, in spite of losing less weight, breast cancer survivors on aromatase inhibitors treated with anti-obesity medications experienced improvements in metabolic parameters. And compared to baseline, at 12 months, the following changes were observed. First, there was a decrease in fasting glucose by 33.9 milligram per deciliter. Second, a decrease in hemoglobin A1C by 1.1%. And 3, a decrease in LDL cholesterol by 15.6 millimole per liter. The control group, the AUM group, experienced improvement in more metabolic parameters, which included fasting glucose, hemoglobin A1C, blood pressure, and LDL and non-HDL cholesterol. Now, were there some variables that predicted better weight loss outcomes in AUM-AI group? The short answer is yes, and the following variables were associated with greater weight loss outcomes: the absence of type 2 diabetes, a higher anti-obesity medication dose, and 3, the addition of behavioral therapy interventions. In conclusion, I want you to take 3 important points from this presentation. First, in this retrospective study, breast cancer survivors taking aromatase inhibitors have a suboptimal weight loss response to anti-obesity medication. 2, in spite of the blunted response, we observed an improvement in cardiometabolic parameters. And 3, a comprehensive weight loss intervention, which includes behavior modification intervention, could improve weight loss outcomes. What about future directions? So future studies should consider the following: a prospective methodology that will allow for a systematic collection of data, including data on calories intake, diet, and physical activity, inclusion of a more diverse population, inclusion of all FDA-approved anti-obesity medication, and also inclusion of a control group of breast cancer survivors who are not using any aromatase inhibitors. And eventually, additional studies should focus on investigating the mechanisms underlying the differential weight loss response to anti-obesity medications between both groups. And thank you.
Thank you so much, Dr. Fonsa. We are now going to begin the Q&A. So if anyone in the room has a question, I know there's some people online too.
Hi, this is Mike Menasha from Helio Endocrine today. My question was for Dr. Fonsa. There's some really interesting data, and I'm curious from a clinical, from a clinical implications point of view. If you're a provider who's treating someone who has obesity and is taking these aromatase inhibitors, is it all about communication and informing them that or adjusting the treatment plan, or maybe informing them about like expectations may be a little bit different for weight loss if they're taking one of these anti-obesity medications?
Sure. So thank you for your question. Yes, sure. So when advising them to take the aromatase inhibitors, I would first tell them that weight gain is a possible side effect, so that I can put them in the image, so that in case they face this issue, they won't be surprised. And also, I would advise them to talk more about it. So at each session that I have with them, I would address their weight fluctuations. And if they experience weight gain, we would tackle it accordingly. I would propose all interventions, and we decide which intervention would work best for them. Thank you.
I did have one question for Dr. Farrell while we wait for the online reporters. Why do you think metabolic syndrome is so prevalent in the Latinx community, and how dangerous is metabolic syndrome?
So we were very fortunate with the AAS data set to have extensive questions from this population, and I think, honestly, a lot of it seems to be cultural. There were comparisons in there looking at who was born in the U.S. versus those who had basically immigrated from other countries, and we were able to compare a bit. I think the cultural aspect of those who were born in other countries, they seem to have increased adverse health outcomes and responses in the data. So I think culture truly does play a large role, but that's kind of what we're hoping to look more into with this data set. This is really just scratching the surface on what we can obtain from looking at such big data on such a longitudinal scale.
Great, thank you.
What was the final
The
part?
second part, just how dangerous is metabolic syndrome?
So cardiovascular disease, diabetes, stroke, these are major health concerns.
Mm-hmm.
This is a very serious problem, and when you're considering that it has been found to be largely in a reproductive population, I think pregnancy just adds a whole nother layer of potential complications related to these health issues. So I do think this is a large-scale problem with expensive potential outcomes that we should be addressing.
Thank you.
We do have a few questions from our live stream. For Dr. Fazaria, Krista Sat in Brazil is asking, many studies are evaluating BMI. Is this the end of the tool, or can it have other uses in obesity screening?
Thank you for that question. I think BMI still has a lot of use. It's one of the most accessible measures. It's simply calculated, it's trackable, it's scalable. So from a population health standpoint, I do think there are some uses for it. But from a clinical, individual patient level, I think it's the start of the end. I think BMI should be supplemented with other measures. The AMA actually on Tuesday put out a policy statement saying BMI should not be used by itself anymore. And I think because there's so many different methods of measuring obesity that are becoming more accessible, like there's scales now that are starting to become FDA approved. There's waist circumference, waist to height ratio, waist to hip ratio. I think there are some other tools that providers can use to supplement BMI. But BMI still is the most researched measure, so I think including BMI is still important, but supplementing it with other measures is also important.
Great, thank you. I have another question for you from Mitchell Zoller at Medscape. BMI is very entrenched in U.S. practice as the main measure of overweight and obesity. What path forward do you see moving away from, hold on one second, a BMI-centric approach, and do you think your findings add to the case for doing this?
Yeah, so similar to the prior response, I think BMI should be supplemented with other measures. And I know it's entrenched in our clinical decision-making. Most of the criteria that we use to screen for things like diabetes focus on the BMI. But I think now as we learn more about the different measures and their validity and also the associated health outcomes, we will slowly move away from BMI. There was a second part to that question, I forgot.
Do you think your findings add to the case for doing this?
Yeah, I think they do. I think our cutoffs right now that we use, they are focused largely on studies that were done in the 1970s, 1980s that were predominantly white European men. And I think showing the racial ethnic differences here, the gender differences, adds to the case that BMI is really maybe even exacerbating these differences or the disparities that we see.
Great, thank you. A follow-up question from Medscape. Is DEXA a good approach for obtaining a better measure of obesity for U.S. adults in routine medical practice?
So we use DEXA as the so-called gold standard for our study because it is a better measure than BMI. It's able to visualize the differences in fat and muscle and bone, but it's not really cost-effective or feasible to do on a large scale. So I do think other measures need to be done. So this is where I think the scales come in, the bioimpedance machines. They're very accessible, cheap, and I think they just need to be validated more. Once they become more validated, I do think those will be the ones that revolutionize how we measure obesity.
Great, thank you. For Dr. Fonsa, I have a question from Kristen Monaco of MedPage Today. Did you find that any of the 3 anti-obesity medications worked better than the others in this population?
Interesting question. So yes, actually, we found that semaglutide was actually the best among the 3. Yeah, and hopefully, like future studies would include all FDA-approved medications, so that we can have a more comprehensive point of view about that question.
How are I'm just from my own perspective, I mean, how are the approval of new medications in the obesity space changing this?
Actually, yeah, the more medication, anti-obesity medication are if they're available, the better it is, because we would offer the patients more options so that they could choose what would suit them most, like in terms of adverse effects, mechanism of action, and like drug intakes and everything.
Great, thank you. Dr. Vasari, I have one more follow-up question from Medscape. Waist circumference is somewhat unreliable and may lack consistency due to uncertainty about the ideal way to measure it. How does this influence its use in routine U.S. practice?
Yeah, thanks for that question. That's actually a very good point. I think one of the reasons why waist circumference is still not included in routine clinical practice is because of what you mentioned, that it's really hard to measure it accurately. I think as we build different protocols and it becomes more inclusive in our practice, I think we will train physicians to start measuring it properly, and I think with that, it will become easier to measure with less variability. But again, this is where I think the bioimpedance scales will also come into play because they're more standardized, and also give body fat percentage, which is a better indicator of obesity.
Thank you. That's all the questions we have from the live stream.
Thanks, Jenny, and thank you all for coming and speaking today. We really appreciate it. As a reminder, the recordings of these news conferences will be available on our website and our YouTube channel. And if you have additional questions or want to set up an interview with one of our presenters, Please feel free to contact us at media@endocrine.org.